A drug that kind of fell by the wayside is ezetimibe or Zetia, which inhibits intestinal cholesterol absorption. Since, as I mentioned in the beginning, liver synthesized cholesterol is more important than dietary cholesterol. Not surprisingly, it is not as effective as the statins. You get about a 17% reduction in LDL cholesterol, and it's used at a fixed dose, 10 milligrams a day. Using more doesn't get you any further LDL lowering. Until the last few years, Zetia was probably the only option for the statin intolerant, but it's now primarily used as an add-on, and that's because the clinical effect is pretty modest. A Improve It trial compared Simba 40 with Simba 40 plus Zetia 10, and the hazard ratio did reach statistical significance, P of less than 0.02, but the hazard was only modestly reduced, and it took almost 5 years for the curves to separate out to a significant level. So it is, it is a drug that has effect, but has a modest effect. The newest trial looking at the value was a trial done in South Korea, which looked at some 3,800 patients with coronary disease and compared rosuvastatin 20 with rosuvastatin 10 plus Zetia 10. And this would fit in with your patients who are somewhat statin intolerant. You can drop the dose of the statin, add on 10 milligrams of Zetia. And there was in the combination group, there was a non-significant trend towards fewer adverse events in the combination group. So I think we can safely say that a lower dose of rosuvastatin plus ezetimibe is non-inferior to a higher dose of the statin. All right. The new stuff, the sexy stuff we're going to get into. The newest drugs that became commercially available over the last couple of years are the PCSK9 inhibitors. The reason we use the abbreviation is because the actual name is quite a mouthful: proprotein convertase subtilisin kexin type 9. It's encoded by a specific gene on the human chromosome 1, and it reduces LDL receptors on the liver cell surface, which induces increased liver synthesis of LDL. So increased PCSK9 leads to elevated LDL cholesterol. There's a small group of patients with familial hypercholesterolemia who have it because of a gain of function of PCSK9. This is what, in fact, led to the study of blocking drugs. And inhibiting PCSK9 leads to lower LDL synthesis in the liver. There are 3 available products that target PCSK9. 2 are very, very similar to each other. The Repatha and Praluent are the trade names for 2 monoclonal antibodies. They are both given subcutaneously, either every 2 weeks or every 4 weeks. Very similar in action, very similar in results. Inclisiran is a different approach, different molecule. It's a small interfering RNA, which inhibits intracellular synthesis of PCSK9. And it's given at baseline, given again in 3 months, and then given every 6 months indefinitely. And we'll talk about these a little bit more. This is one of the antibody drugs showing you what it is doing, that it binds PCSK9, affects the LDL receptors on the liver, and reduces the synthesis of LDL cholesterol. Dramatically effective in terms of lowering LDL cholesterol. All 3 available products, whether used as monotherapy or added on to a statin, will reduce your LDL by about 50%. The dosing, pretty standard with alirocumab. You start with 75 every 2 weeks. If you don't get the results you want, it can be increased to a maximum of 150 every 2 weeks. And if that is working, you can switch to 300 every 4 weeks. The Velocumab, again, starts off Q2 weeks. You can also use a slightly larger total dose on a monthly basis. They work equally well. Inclisiran has a single dose, comes in a single injectable vial. Give it once, give it again in 3 months, and then every 6 months. They lower cholesterol, unequivocally proven. How well do they work in terms of helping your patients? There have been a couple of large trials recently reported. The Odyssey trial looked at some 19,000 patients who were 40 or older who were hospitalized with an acute coronary syndrome, either unstable angina or MI within the prior year, and who had an LDL of 70 or greater despite a maximum tolerated dose of statin. And this is going to be a repeat theme in these drugs, is all of them to get into the trials had to be on a maximum tolerated dose of statin. LDL was reduced from 93 in the placebo group to 40 in the antibody group, as would have been predicted. Follow-up mean a little under 3 years, and major adverse coronary events were reduced 15%, from 11.1 to 9.5, so an absolute drop of about 1.6%. Number of deaths, where there was a trend to fewer deaths, but it did not reach statistical significance. Remarkably well tolerated, as you'd expect, with some injection site reactions. There was some increase in nasopharyngitis. There's no evidence of cognitive impairment, liver impairment, or myalgia, and there were no drug-drug interactions found. So very well tolerated, very effective at lowering cholesterol, moderately effective at reducing coronary events. The Fourier trial, even larger, so over 27,000 patients between 40 and 85 who had clinical coronary disease, LDLs 70 or greater on a maximum tolerated statin, and they were followed up not quite as long, for a mean follow-up of a little over 2 years. Again, you saw the dramatic drop in LDL cholesterol, 92 in the placebo group down to 30. Major adverse cardiovascular events reduced by a similar degree, 15%, and an absolute 1.5%. And deaths, so there was no significant difference. There was some number of secondary analyses done of this large trial. They looked at people who had metabolic syndrome. They had a similar LDL lowering, and they had a higher baseline event rate, but a similar lowering. There were the Fourier open label extension, followed some 6,000 patients from the original Fourier trial, about half of whom had been on active drug, half on placebo, followed them for another 5 years. So they had the groups that had been on active drug the longest that were followed for almost 9 years. After 12 weeks on active drug, there was a median LDL of 30. 2/3 of the patients had an LDL below 40. Same story, 15% reduction in major adverse events, some 20% lower risk of MI, stroke, or cardiovascular death. So these drugs work, and they seem to keep working. One issue that was brought up when people looked at the sort of results you could get from the antibody drugs was, is it possible that you're taking your cholesterol too low? Cholesterol is not arsenic. Cholesterol is an important compound that's used in the human body. It's part of the cell structure. Cholesterol is a building block for a number of sex hormones. And so there was at least theoretical concern that dropping the LDL cholesterol as low as could be done might in fact be dangerous. Looked at the longer term, the open label extension of the Fourier trial, 24% of these patients had LDLs below 20, and fully 2/3 were 40 or below. So, these were dramatic lowerings of cholesterol. And when they looked at the different groups by the level of cholesterol lowering, the lower the LDL cholesterol, the fewer primary, secondary endpoints, and there was no increased risk of side effects. So it does not appear, in fact, that there is any harm from getting LDL cholesterol down to these basement levels. Inclisiran also targets PCSK9, but does it through a different mechanism. One of the attractive features of the drug in the initial working was that it is very specific to liver cells. If you give an IV infusion and look 24 hours later, you can find none of the medication in the serum. It's all gone intracellularly, and it decreases both intra and extracellular PCSK9. And because of its mode of action through RNA, it gives a very long-acting lowering of LDL cholesterol. And its maintenance, it's used every 6 months. And there's pretty good evidence that if you're using it for primary prevention, you can, in fact, probably give it once a year. So for people who don't like the idea of getting an injection every 2 weeks or every 4 weeks, this is a pretty good option. Much smaller trial, the Orion trial, but again, it looked at 2 groups of patients. It looked at those that had stable coronary disease or who had LDLs greater than 70, or high-risk patients who had LDLs over 100, again, on a maximum tolerated dose of statin. Their follow-up was shorter, only a year and a half. LDL cholesterol reduced by 50%, and adverse events, cardiac adverse events, reduced by 26% relatively, and a fairly impressive 2.3% absolutely. And it was dominated by a decrease in cardiovascular deaths, which is my favorite hard endpoint. Well tolerated, no liver, kidney, muscle toxicity. And when the open label extension showed that the cholesterol reduction was long acting, that after 4 years after the initial trial, LDL was still reduced 44% from baseline. So we now have 3 good drugs. This is a little schematic of Inclisiran's working. I don't think it adds much.